Finance Committee will come to order. Today we're going to discuss the scourge of the deadly synthetic opioid fentanyl. Fighting fentanyl requires fitting together all the pieces of the puzzle. Already this year, Congress has acted to disrupt the flow of fentanyl from countries like China, thanks to the work of Senator Brown. Today, what we are going to be digging into is the issue of how the healthcare piece fits in. These healthcare issues have not had the attention they deserve. My colleague from the Pacific Northwest, Senator Cantwell, has been leading the way in our region. I want to thank her for attention to this issue, and she has invited a guest who has some really promising ideas for how we could have some real healthcare breakthroughs here. The epidemic has hit communities in the Northwest like a wrecking ball. The healthcare puzzle piece is about real people whose lives have been ripped apart by the devastating disease of addiction. I'm going to focus my remarks on just a few areas that need immediate attention. The first is prior authorization. Only 1 in 5 Americans receive life-saving medication treatment for opioid use disorder, despite the evidence that it works. 2 months ago, Congress passed a law that I and others championed requiring state Medicaid programs to cover medication-assisted treatment. This approach, MAT, if we take it on a permanent basis, could really be the gold standard treatment for opioid use disorder. And one of the reasons that we're digging into this issue this morning is I'm concerned that big health insurers like United Health and Aetna that contract with the Medicaid program are using prior authorizations at high rates, and that is causing delays and denial of this important treatment. In the context of the opioid epidemic, private prior authorization can be the difference between life and death. If somebody walks in for treatment for their opioid use disorder and gets stymied by prior authorization, they may just never get back, never return, dying from an overdose before the prior authorization is approved. Last fall, we launched an investigation looking into how these big insurance companies are ripping off taxpayers and Medicaid and patients by using the Medicaid program as a piggy bank through tactics like prior authorization. As patients suffer, as these mega corporations post record profits, they're also dragging their feet as the committee tries to get answers about several of these tactics. These multi-billion-dollar companies owe answers to taxpayers about how these Medicaid dollars are being used. Next, I'd like to talk about opioid use disorder for individuals that are coming out of prisons and jails. I've heard repeatedly now from law enforcement officials in rural Oregon that these individuals need to be able to get adequate treatment for the disease during and after their sentence. Making these reforms is common sense. States are working on their own initiatives to support access to care for people before coming out of incarceration who need uninterrupted care. And I especially want to credit state legislators like Pam Marsh from Southern Oregon and the sheriffs from across Oregon who are leading the effort to get this done. These reforms are a start towards being responsive to what law enforcement officials are asking for, getting people off their addiction before they get out of jail so they do not come back. I'm going to wrap up by talking about prevention and thoughtful approaches to pain management. More needs to be done to head off opioid use in the first place and encourage more non-opioid pain management to be used in American healthcare. There are promising new therapies in development that block pain signals rather than flooding receptors in the brain with opioids that create an addictive feedback loop. Members of this committee are watching the development of these therapies closely. I encourage this, and we're going to look for ways to accelerate their entry into the healthcare system. Every single member of this committee understands the healthcare anguish and pain that opioids bring to our communities from one end of the country to another. We've got an excellent panel of witnesses. I'll have a special introduction from our friend from Oregon here in a little bit. but I want to thank all our guests. We're talking about breaking down the remaining barriers to healthcare treatment in this crucial area. Save lives, get struggling Americans the help they need. Senator Crapo.
Thank you, Mr. Chairman. The fentanyl crisis has devastated communities across this country. Far too many families have experienced the pain of losing a loved one from this deadly substance, and the threat it poses to our communities and neighborhoods cannot be overstated. In Idaho, overdose deaths involving fentanyl increased nearly 14-fold between 2017 and 2022, an alarming statistic. It's important to note that this crisis and the uncontrolled flow of fentanyl into our communities has not occurred in a vacuum. In the last 2 decades, we saw an unprecedented increase in the use of prescription opioids, causing overdose deaths to rise dramatically. Congress took critical steps to authorize programs to reduce the use and supply of prescription opioids and to expand access to treatment for those who need it. In recent years, as prescription opioids have become harder to obtain, illicit fentanyl, a cheap, widely available, and potent drug, entered the drug supply, making overdoses even more unpredictable and deadly. According to the administrator of the Drug Enforcement Agency, fentanyl is the deadliest drug threat our nation has ever faced. While this hearing is focused on the prevention and treatment, we cannot ignore fentanyl's alarming supply chain. It is well documented that China is a primary source of fentanyl precursors and analogs. And I joined several of my colleagues on both sides of the aisle in pressing China on its role in the fentanyl crisis on a trip to that region late last year. These precursor chemicals are shipped either directly to the United States or to Mexico-based drug cartels and smuggled across the southern border before they are pressed into counterfeit pills, mixed into other illicit drugs, or manufactured into powder form. Any conversation about illicit fentanyl must acknowledge the role of this administration's porous border policies, which have given drug cartels easy access to our neighborhoods and communities. Any efforts to bolster healthcare services for treatment and prevention cannot fully remedy the fentanyl crisis unless we also eliminate its supply. This committee has acted on a bipartisan basis to consider a number of policies that expand access to mental health and substance abuse disorder treatment for those who need it. This includes consideration of the Better Act, legislation that was passed out of this committee last fall. A number of policies included in the Better Act were recently signed into law, including permanent Medicaid coverage for medication-assisted treatment, expanded access to residential substance use disorder treatment, and treatment for Medicaid patients, and guidance to states to improve the availability of substance use disorder services for those enrolled in Medicaid and CHIP. I welcome continued consideration of policies that improve the provision of care, including through the use of telehealth, which has dramatically transformed the availability and provision of mental health care and substance use disorder services for millions of Americans. This committee has made a lot of progress in expanding access to care, and I look forward to working with my colleagues on targeted policies that can make a difference and address the root causes of the fentanyl crisis. Thank you to our witnesses for being here today and for all the work that you do in our communities. I look forward to your testimony. Thank you, Mr. Chairman.
Thank you, Senator Crapo. And Senator Crapo has highlighted that this crucial issue, this crucial health care issue, has always been bipartisan here. And on my watch, we're going to continue that. I'm going to introduce several of our guests, and then I'm going to yield to my friend from Washington State to introduce Dr. Caleb Bonta-Green, who is doing extraordinary work in the Pacific Northwest with what I think is a breakthrough set of opportunities. Mr. Vazina is the executive director of the Fourth Dimension Recovery Center in my hometown in Portland. He's also a person in long-term recovery. Fourth Dimension is a recovery community organization providing a variety of addiction recovery services to adolescents and young adults. I'd also like to tell my colleagues how it is that Mr. Vazina is sitting in that chair with us this morning. A few months ago, I was shopping in our legendary grocery store in the Pacific Northwest called Fred Meyer. I have had the honor of having a chicken in every Fred Meyer in Oregon. There are more than 50.
How many?
There are just over 50. I have been to all of them, and we can discuss that, later. And Mr. Vazina came up to me, a little bit stunned that I was standing there with him, and started telling me some of the things that were crucial in terms of healthcare treatment in this area. It wasn't politics, it wasn't the Democrats and Republicans. He said, this is what we need to do. And so all of us try when we're home to get out and listen. Mr. Vazina is here because he was in Fred Meyer when I was, and I really thank him for coming. Our next guest will be Dr. Abigail Herron. She's Vice President and Chief Behavioral Health Officer at the Institute for Family Health in New York. She's board certified in adult psychiatry, addiction psychiatry, and addiction medicine. These are all going to be excellent witnesses. And then let me go to the end of my list and yield to Senator Cantwell. Dr. Jean Marie Perron is an emergency medicine physician and toxicologist, as well as a professor in the Department of Emergency Medicine, and the founding director of the Center for Addiction Medicine and Policy at the University of Pennsylvania. She leads a very important program that I have learned about in the treatment of substance use disorders in the emergency department. And she's also using telemedicine in a very creative way, and we appreciate that. Senator Cantwell, you've got a terrific guest here, and why don't you introduce?
Thank you, Mr. Chairman, and to the Senator Crapo for having this important hearing. I'd like to introduce Dr. Banta Green, a research professor in the School of Medicine at the University of Washington, an adjunct research professor at the University of Washington School of Public Health. He is also director of the Center for Community Engaged Drug Education, Epidemiology, and Research within the Addictions, Drug, and Alcohol Institute. In his role, he leads research to generate evidence-based solutions to the opioid crisis. He also serves on local, state, and federal working groups and committees related to interventions for those who use illicit substances. In 2012, he served as senior science officer for the Office of National Drug Control Policy in the Executive Office of the President, and I'm confident that his experience in developing evidence-based treatment solutions for substance use will generate much-needed insight during our hearing today. Dr. Green participated in a roundtable that we had about treatment models, but his research on what are community-based treatment models and health engagement hubs, I kind of say similar to how Senator Stabenow added mental health to the community on top of our already existing infrastructure, so it saved dollars. But his research on these hubs have showed a 68% reduction in overdose of deaths. So to me, this is something we need to understand, see if we can implement this. In King County, we lost 1,000 people last year from opioid overdose. So I look forward to the discussion today on how we leverage these opportunities for community-based treatment so we can get something implemented as quickly as possible. Thank you, Mr. Chairman.
Thank you, Senator Cantwell, and thank you, Senator Cantwell, for taking the lead in our part of the country. We have been so hard hit. We are really looking for breakthrough answers, and to have Dr. Banta Green and Mr. Vazina here today from the Pacific Northwest is terrific. So let's go right to our witnesses. We'll make your prepared statements a part of the record. If you all can take 5 minutes or so, we'll begin with you. And Dr. Vazina, again, thank you for that day when you came up to me and said we ought to do this. Welcome.
Yeah, maybe we can get chicken after this.
You got it.
Chairman Wyden, Ranking Member Crapo, and members of the Senate Finance Committee. My name is Tony Vesna. I'm the Executive Director of 4D Recovery. I'm also the Chair of Oregon's Alcohol and Drug Policy Commission, though my remarks today do not represent these organizations. It has been 11 years, 11 months, and 26 days since the last time I used heroin or any other substance. On July 19th, 2012, I was arrested at a convenience store in Portland, Oregon for possession of heroin, and I haven't used since. I had wanted to quit for some time and had attempted treatment several times before that. My motivation to get sober was simple. It was for my daughter. I had made a promise to myself at a young age that if I ever had a kid, they wouldn't know the isolation and despair I felt as a result of my parents' addiction. I was born in Idaho, but my mom fled when I was young to Camas, Washington to get away from drugs and crime my father was involved with. I partied in high school like other kids, but unlike some of my peers, I had a predisposition to addiction. A combination of genetics, circumstances, and my own personal choices resulted in a 9-year opioid career, which took off in high school when my mother was prescribed an absurd amount of OxyContin. Everyone is aware of how OxyContin impacted our nation, and now we're facing a drug that is much more powerful, addictive, and lacks government oversight. Fentanyl, or what the kids that I work with call Fetty. According to the CDC, over 20 teenagers die every week from drug overdoses, and fentanyl is the leading cause of death for this age group. I can hope my testimony today moves this committee to advance our nation's response to our addiction crisis, because I know that people can and do recover when they're given the tools to do so. This committee can address the crisis in many ways, but I'll highlight a few that draw from my personal and professional experience. Foremost, we need to protect our children by preventing them from becoming addicted in the first place with primary prevention, and then swiftly intervene with school-based interventions and connections to critical treatment and recovery services for those who have substance issues. I believe we could utilize CHIP funds to bolster prevention and school-based interventions. We can increase Medicaid rates and provide startup funds for new treatment programs. According to the Substance Abuse and Mental Health Service Administration, 97% of adolescents with a substance use disorder in 2022 did not receive care. And according to the National Institutes of Health, the average wait time for an adolescent residential treatment bed is 28 days. This is unacceptable. We must capitalize on the opportunity to provide treatment immediately when people seek it. When I was addicted, if I had to wait for treatment, there was a good chance I would not make my appointment. And with the fentanyl risk of fatality, it is more important than ever to create access on demand. We can increase access to peer-delivered services by allowing Medicaid billing in recovery centers and also pre-treatment engagements. Recovery centers provide sober social hubs for people in recovery to build relationships and access recovery support groups. I still attend recovery meetings today, and they still keep me sober. Pre-treatment peer outreach services allow people in recovery like me to go out and encourage people using to seek help. We can fund recovery residences, also known as sober livings. After leaving residential treatment, I moved into a sober house and lived there for a few years. Being around other sober people reinforced my commitment to recovery and provided time for me to go to college, pay off debt, and purchase my first home. Lastly, we can increase access to medication-assisted treatments. This is probably the quickest way to address the issue. Some people balk at this proposition because they think it's replacing one drug with another, and I used to think that, but I realized that it's more like other replacement therapies. Take smoking cigarettes, for example. If a person was to quit smoking and switch to patches, nobody would say anything. I have a large scar on my left forearm from an abscess I got from injecting Vicodin. Apparently, you can't do that. While I was in the hospital, I was detoxing from heroin. I begged the medical staff to prescribe me medication, which they did not. They did, however, later on have a pre-stop by, which I did appreciate, but I didn't think you could exercise the addiction out of me. And so I left the hospital daily to get well on heroin. If that were me today, the likelihood I would have overdosed would be exponential. We must provide people with medication-assisted treatment, especially those exiting jail. A vast majority of people in jail have an associated addiction with their crimes. I'm not advocating for abolishing jail. You know, it saved my life. But I do think we should rehabilitate people so that when they exit, they can reenter society as contributing members. This week, a classroom full of American teenagers will die from drug overdoses. You know, I have 3 kids. They're very important to me. The likelihood that they'll have addiction is pretty high, given my family. And I just really hope that and implore you all to take swift action that expands access to care and ultimately saves lives, because our kids depend on it. Thank you.
You make Oregon proud, and especially Portland. Dr. Herron.
Chairman Wyden, Ranking Member Crapo, and members of the committee, thank you for the opportunity to speak with you today. As a psychiatrist specializing in the treatment of addiction, I've had the privilege of caring for individuals with mental health and substance use disorders for the past 20 years. I'm the Chief Behavioral Health Officer at the Institute for Family Health, which is one of the largest federally qualified health centers in New York State, where we provide outpatient services for people affected by opioid use. My career has been defined in many ways by the opioid epidemic, and more recently, the rise of illicit fentanyl, which has catastrophically worsened this public health crisis. Fentanyl is a synthetic opioid, a member of the class of medications called opioid analgesics, which are used for pain relief. While opioids do have legitimate medical indications, they carry a high liability for misuse because they also produce euphoria. Opioids can cause respiratory depression, which suppresses the body's ability to breathe adequately. In an overdose, this can progress to loss of consciousness, coma, and death. Synthetic opioids, primarily fentanyl, are currently the main driver of deaths due to overdose. Fentanyl is highly potent, about 50 times stronger than heroin and 100 times stronger than morphine. Taking even a small amount of fentanyl can result in a fatal overdose. Illicitly manufactured fentanyl is inexpensive to produce, leading to the sharp increase in its availability. Fentanyl is found in illicitly obtained opioids, including heroin, and is also pressed into pills where it may be marketed and sold illegally as prescription opioids. It's also passed off as non-opioid substances such as benzodiazepines, cocaine, or methamphetamine. When an individual has not used opioids and therefore has no tolerance to the effects of them, and they're exposed to fentanyl, the risk of overdose is especially great. Safe and effective treatment for opioid use disorder, such as the prescription medications buprenorphine and methadone, are available. However, individuals can face barriers when attempting to access this type of treatment. Addiction treatment needs to be fully integrated into mainstream healthcare so that we are prepared to welcome patients into care through multiple entry points. At the Institute for Family Health, we practice an integrated care model, which allows patients to receive primary care, behavioral health care, and addiction treatment in a shared treatment setting. Co-located, integrated care increases patients' acceptance of behavioral health care and reduces stigma in accessing services. There are challenges to the implementation and expansion of the integrated care model, however. In New York and elsewhere, same-day billing restrictions on medical and behavioral health services prevent a single provider entity, such as a federally qualified health center, from billing insurance for a medical visit and a behavioral health visit provided to the same patient on the same day. This creates barriers for patients who face transportation and scheduling limitations that can be common in low-income populations. In addition, there's a tremendous need for better reimbursement for case management, screening, and preventive mental health services. All health professionals should receive education and training in substance use disorders and available treatments. At the Institute for Family Health, we focus on training the next generation of providers ready and willing to incorporate addiction treatment into community-based services. We've made treatment of substance use disorders a core component of our primary care residency training programs, and we operate an accredited fellowship program in addiction medicine. HRSA's Teaching Health Center graduate medical education program supports innovative community-based residencies like the Institute for Family Health's programs. Continued funding for this program will ensure that medical, dental, and psychiatric residents receive training in outpatient safety net provider settings. The rise of telehealth over the past several years has led to a great improvement in access. In addition to combating workforce shortages, telehealth decreases delays in accessing care, provides expanded availability outside of traditional treatment hours, boosts communication between patients and their clinicians, and enhances engagement in care. During the COVID pandemic, many restrictions on telehealth services were temporarily lifted, and reimbursement rates were on par with in-person services. It is vital that we maintain these flexibilities, including prescribing medications for opioid use disorder via telehealth. Telehealth payment parity is also a crucial component of the ability to combat the fentanyl crisis. Full payment parity for telehealth services, and not just coverage parity, will require insurers, including Medicare, to pay for telehealth and in-person services at equal rates. Underserved communities and health center patients deserve access to telehealth. Without payment parity, many healthcare providers will be forced to limit or eliminate telehealth services because they cannot afford to provide care at reduced reimbursement rates. Thank you for allowing me this opportunity to share my thoughts and experiences from throughout my career. On behalf of the Institute for Family Health, I appreciate this committee's commitment to combating addiction and expanding access to treatment and recovery. I welcome your questions once testimony has concluded.
Thank you very much. We'll have questions in a moment. Dr. Banta-Green.
Good morning, Chairman Wyden, Ranking Member Crapo, and members of the committee. Thank you for the opportunity to speak about this critical topic, and thank you to Senator Cantwell, my senator, for your consistent and impactful leadership on addiction. It is heartening to see the leadership of the Pacific Northwest, Idaho, Oregon, and Washington really demonstrating their leadership by holding this hearing. As a health services and public health researcher, it is an honor to participate. My name is Caleb Banta-Green, and I have worked to support individuals and communities impacted by opioid use disorder for nearly 30 years. Over this time, the predominant opiate has changed multiple times, and models of care and treatment medications have evolved. We have made a dent in the treatment gap that is, the gap between those with active opioid use disorder and those on the medications methadone and buprenorphine. These medications are the most evidence-based treatments for opioid use disorder. They support ongoing recovery and they reduce mortality by at least 50%. Unfortunately, the treatment gap persists, with approximately 3/4 of those with opioid use disorder not on life-saving medications. Opioid treatment programs, primarily using methadone, and medical office-based treatment using buprenorphine are excellent models of care. Yet despite our decades of effort to expand these models of care, they continue to serve the minority of people with opioid use disorder. Policymakers and healthcare systems continue to improve these two models of care and expand access, but it is clear we need a new third model of care as well. Non-pharmaceutical fentanyl has exacerbated this need for a new model of care. Fentanyl is a very potent and inexpensive drug that presents substantial risk for rapid development of opioid use disorder and high risk for overdose. Fundamentally, we need to make it easier to access treatment medications than it is to access fentanyl. As part of our ongoing research, we regularly interview people who use drugs and are accessing overdose and infectious disease prevention services. Our published research shows that 80% of people who are misusing opioids do want to stop or reduce their use. 70% do want to be on these life-saving treatment medications, and yet most are not able to access care in the traditional healthcare and treatment systems. Further, 3/4 of these folks want to obtain healthcare at these community-based programs at a place where they know and with people with whom they trust. Over the last 10 years, we and others have been developing and testing new models of care based on clients' stated needs, health services and public health data, and research-supported interventions. We are combining a low-barrier clinical model with community-based access points and a team-based model of care. To support the treatment medication prescriber, we have added nurse care managers, mental health care managers, and care navigators. These folks provide the majority of face time with clients, and they provide vital supports so that people can start and stay engaged in care. People in recovery from opioid use disorder have served in these medical and care navigator roles, and their insights and ability to quickly build trust with clients have been invaluable. This new care model has positively influenced the care continuum that you're seeing up here. We are finding that jails and emergency departments that were once hesitant to start people on medications because they didn't think they would show up at a medical appointment in the next week or two, they're now starting people on buprenorphine because they know there is a place in the community providing drop-in access to medications and other supports. These community-based health hubs for people who use drugs are showing positive outcomes, including in our research with 6 rural and urban communities across Washington state, where we found significant increases in buprenorphine use and significant declines in deaths. To date, these programs have been funded with one-time funds, including grant dollars. What we need is a bundled care model, an alternative payment model, with adequate funding to pay for the complete care team in these community-based settings. Again, we need the flexibility in locating community care and adequate funding for the entire care team to manage this complex, chronic, relapsing medical condition. As one of our clients, an older, unhoused woman with long-time opioid use disorder in Eastern Washington, she told one of our community staff, "I've been in and out of treatment throughout my life, and you are the first people to treat me well. So I keep coming back, and I've brought my friends." Opioid use disorder with fentanyl is tough, but we have a third model of care that can help us dramatically close the treatment gap, support recovery, keep people alive, and help restore the health of individuals and their communities. Thank you very much for your time, and I look forward to your questions.
Well, Dr. Banta Green, I'm trying to recover my jaw because it's dropped sort of at the description you've given of a promising new treatment plan, and we're just going to probably turn you and Senator Cantwell loose to get this done because it's very exciting. Appreciate your being here. Dr. Perron.
Chairman Wyden, Ranking Member Crapo, and members of the committee, thank you for inviting me to share my experiences as an emergency physician in a busy hospital in Philadelphia. Although the statistics we have heard today are dramatic, nothing is worse than facing a parent whose son or daughter has been brought to our hospital after a fentanyl overdose. The struggles of a family battling opioid addiction and navigating the healthcare pitfalls in this chronic relapsing disease are heartbreaking. In the chaos of missed appointments, we recognize that the emergency department can be a gateway to same-day treatment, initiating the first dose of life-saving treatment with Suboxone or methadone. Multiple randomized control studies have built the evidence demonstrating that treatment with these medications can reduce the risk of fatal overdose by 65%. Yet only 11% of people with opioid use disorder receive these medications. Appointments, insurance, transportation, and pharmacies stand in the way. We started a program to provide these medications in our emergency departments in 2018. My colleagues have been trained in prescribing, and our nurses help to identify and support patients to take that step. Tuesday overnight in the emergency department this week at 2 in the morning, I saw 3 patients with opioid use disorder, one who was seeking treatment who was started on methadone, one who had been revived from a non-fatal overdose with naloxone, and one young woman, particularly memorable, who received her first dose of Suboxone and was discharged with a prescription alleviating her withdrawal symptoms and with follow-up to our telehealth program, our peer-led model. I would have liked to have started her on a long-acting injectable medication, but that is not available. This is one aspect of low-barrier treatment, meaning that the patient doesn't need an insurance card or an ID and doesn't need to wait weeks for an appointment or be subject to various scrutiny, all of which can derail early attempts at recovery. Telehealth has now created a critical safety net, more cost-effective than the emergency department and more patient-centered than other care settings. Our Care Connect Warm Line offers free telehealth substance use navigation and same-day clinician appointments to start treatment with Suboxone. We leveraged our peer-led model to staff 9 a.m. to 9 p.m. 7 days a week. We have now treated over 2,000 patients, including 10% of our patients who report release from incarceration in the past 30 days. Implementing this important safety net for citizens re-entering the community mitigates this high-risk period and is critical to closing the treatment gap that patients face when they leave carceral settings. We have also expanded other services for this vulnerable population, including assistance navigating insurance applications, phones, and transportation to future appointments. A Ryan White funding model could be used to establish regional networks of telehealth addiction bridge treatment to prevent gaps in care and continue patients on medication during care transitions. We have found that 2/3 of our telehealth patients were recently on Suboxone, yet were discharged from a care setting without a timely follow-up, or lost insurance, or faced a life event where their care was disrupted. Experiencing opioid cravings without medications drives patients back to the street, only to face the most lethal supply and potentially overdose. Creating low-barrier models such as telehealth bridges enhance retention. Telehealth can also solve long appointment wait times in rural areas due to provider gaps. We must sustain current exceptions to federal regulations for telehealth and create billing parity for these services. Telehealth can also address treatment access disparities. In the Philadelphia area, there's been a 30% increase in fatal overdoses in communities of color since 2020. Fentanyl adulteration of the stimulant drug supply has yielded a new cohort of patients with opioid exposures. Qualitative interviews from our community share that they want more privacy in their substance use treatment options. They don't want to wait in lines outside of opioid treatment programs. We need to focus on developing culturally informed treatment, medication education, and harm reduction tools to address these disparities. Telehealth can help establish care with privacy and then transition patients to a primary care integrated model where patients can receive their addiction care with their hypertension and diabetes medication, all from one trusted provider. Our patients transition from our ED or telehealth visits to our primary care practices. This integrated model needs to be expanded and reimbursed to sustain discrete treatment options. This requires investment in clinician workforce, including expanding addiction medicine training and graduate medical education, and support for expanding capacity for more trainees for addiction medicine fellowships. Our programs utilize the wisdoms of peers like Mr. Vitzina, who build alliances with patients and help them navigate the early treatment journey. Peer training provides a pathway to employment for people in recovery. We must expand these programs by developing billing and reimbursement strategies for these services. Their journeys destigmatize and provide role models to our community members struggling with addiction and are a source of inspiration. People do recover, and we need to share that narrative. Thank you again, and look forward to your questions.
Thank you. It's been a terrific panel. Let me start with you, Mr. Vesna, and set the table this way, because this committee's got a lot of history in this. We felt some time ago, Senator Crapo and I, Senator Stabenow, Senator Cornyn, that one of the key pieces for the treatment gap was schools, that you really had to get these services into the schools. So when we dealt with the gun safety legislation here a couple of years ago, Senator Crapo and I basically had black letter law ready to go that we could give to Senator Stabenow and Senator Cornyn. And those two did a terrific job as we molded this gun safety legislation, in particular to pay for more behavioral health services in the schools. That's essentially what we were able to do working with the leadership, Senator Stabenow and Senator Cornyn. So my question to you is, here you are having battled this for quite some time. What supports and services would have been helpful to you in your youth to ward off the addiction? Just put yourself in that kind of role, because your expertise would be terrific. And as we started talking, earlier in the grocery store, I think we really need to learn from our experiences.
Sure. Chairman Wyden, Ranking Member Crapo, and the other Senate members. Thanks for the question. I think there's a few different things we could do in school-based settings. First and foremost, like I said, we need primary prevention strategies that educate kids and give them the tools around drug use. Secondarily, I think we need to educate kids about recovery. When I was in high school and I was using a lot of drugs, there was a wrestling coach at my school. He was really good, and I had found out that he was in recovery from addiction, and I had looked down on him for that at that time because I had no concept of the disease model of recovery. It wasn't until I got into recovery and I learned about the disease model that I realized it wasn't a moral failing. It was a disease that I had that could be put in remission. And then I think having peers in schools would be good to talk to kids who exhibit symptoms of substance use disorder. And then lastly, for kids who have substance use disorder that's more chronic and severe, recovery high schools have shown to be efficacious. And I helped start one in Oregon. We've been working with those kids regularly. Thank you.
Well, we'll be following up with you because this issue is going to have to be tackled again. And I remember my colleague, Senator Stabenow, with her hallways to health, and that really summed it up. And so this has been part of our committee's kind of focus, is to take our area of jurisdiction where we could have an opportunity to make a difference. And thank you for making the trek. I know little about most subjects, but I know everything about airline schedules, and it is hard to get here except for our one nonstop. Question for you then, Dr. Banta Green. I think you could tell from my comments, earlier, I am outraged at the level of abuse with this prior authorization. I think it is being used too often by big insurance companies to basically pad their pockets, and they're not doing what's needed for Medicaid and for patients. And I know from having talked with Senator Cantwell, you've got some thoughts on this, and give us your sense about what the impact prior authorization has on access to treatments, A, and then B, what should we be doing to get more people on opportunities for Medicare and Medicaid, our committee's jurisdiction, and get the help they need?
Thank you for the question. You've heard what a life-threatening condition we're talking about in the moment, every day. People are often using fentanyl 10 or 20 times a day, and every time they're using, it's a risk for overdose. So any delay in accessing care with these medications, methadone and buprenorphine, increases the chance of death. So that's really the fundamental impact of prior authorization, is any delay in care can be life-threatening. A somewhat more subtle point, but also important, has to do with dosing and which doses are allowed. We started off with how we dosed buprenorphine, in particular, at fairly low doses, and the research keeps showing that the higher doses you use, the better folks do. The easier it is to get them started on the medications, and the better they will stay engaged in it. If we use low doses at the outset, people may have a bad experience and think that buprenorphine doesn't work, when perhaps the dosage wasn't working. And so it has this unintended consequence in that way. Another aspect of prior authorization, which we know from an insurance perspective has to do with moral hazard. We think people are somehow going to overuse or misuse that substance. That doesn't make sense in this context, is cost containment. And one of the really important issues that was brought up are these long-acting injectable forms of buprenorphine that can last a week or a month. These are very expensive. And they're very effective. We are hearing it's really emerging in the last 6 to 12 months how much providers and patients are really liking these medications and doing really well on them. So that cost issue around the long-acting injectables is also going to be a factor when it comes to prior authorization.
Thank you. Senator Crapo.
Thank you, Mr. Chairman. And Dr. Perrone, in recent years, we have begun to see an emerging pipeline of non-opioid medications and devices with serious potential for pain management. In 2022, our committee worked to advance access to these options by addressing problematic reimbursement policies through the No Pain Act. As safe and effective alternatives to opioids come to the market, policymakers will need to continue identifying and addressing potential barriers and disincentives. What steps, or legislative or otherwise, do you think would help ensure providers and patients can access these non-opioid options as they come to market?
Thank you, Senator Crapo, for the question. We have spent a lot of effort decreasing opioid prescribing. We have done a lot of clinician education. There have been policies put in place at state levels of limiting numbers of opioids, which have been very effective. So a typical prescription might be previously for 30 pills and now is limited to 10. Those really help us divert from opioids to non-opioid pain medications. Depending on the cost of, we have a lot of very effective non-opioid pain medications that were underutilized in the opioid era. Medications like acetaminophen, Tylenol, ibuprofen are incredibly effective. I can remember I was a doctor at a summer camp, and there were young women coming to camp with Percocet or oxycodone for menstrual cramps. So we've moved very far away from the overprescribing of opioids, but there have always been very effective analgesics, like I mentioned, that can actually be used. If we have new non-opioid, non-addictive medications, we would want to use them, but we'd also want them to be compared to current non-addictive medications that are very effective.
Well, thank you. And while I'm visiting with you, I'd like to go to Xylazine. The DEA DEA Administrator Milgram recently stated that Xylazine is making the deadliest drug threat to our country that we've ever faced, fentanyl, even deadlier. While this hearing is focused on fentanyl, I'm concerned that the parallel rise in the presence of Xylazine and FDA's warning that is undetectable using routine toxicology screens is a problem. How has this co-occurring rise in Xylazine complicated your ability to recommend and provide treatment for patients?
Thank you again. Very good question. In Philadelphia, the fentanyl supply has been adulterated with a veterinary tranquilizer called Xylazine, sometimes called Tranq, and it has been convincingly impacting our patient population. It's been associated with wounds, really significant wounds, like Mr. Vezina mentioned about wounds on his arm. We're now seeing a different kind of wounds, and these wounds on patients who are housing challenged really fester and progress, and so that when they finally come to the emergency department, because they have wounds, they actually need to be hospitalized, and then after hospitalization, it's very difficult to send them to rehabilitation facilities because most of the rehabilitation facilities can't accept patients with wounds. So it's a big catch-22 that's limiting our ability to get the most vulnerable patients who need the help the most into treatment. However, I don't want to misguide you, and I think as Ms. Milgram said in her statement, our deadliest drug is fentanyl. Fentanyl stops people from breathing, and all of the Xylazine is accompanied by fentanyl. So we still have naloxone that reverses the fentanyl component, so patients do get revived with naloxone. They may still be sleepy, but they're breathing. So I want to keep the focus on fentanyl as the most important drug we need to focus on. We have one antidote that works incredibly effectively. We don't need 10 antidotes. I don't want to be distracted by all these other drugs coming into the drug supply because it's really mixed with fentanyl, and fentanyl is the deadliest component of all of this.
Thank you. And well said. My last question, Dr. Banta-Green, will be to you. In 2023, law enforcement seized a record number of counterfeit pills containing fentanyl, more than double the amount in 2022. While there are many people who knowingly consume fentanyl, I'm concerned by the number of fentanyl-involved overdose deaths among young people, despite declining drug uses in that same population. How's the proliferation of fentanyl-laced counterfeit pills impacted the efficacy of overdose prevention and other harm reduction efforts?
Thank you for the question. We're seeing really profound differences in substance use disorder with fentanyl for youth. We've just conducted research, and our preliminary results show that the time from use to developing use disorder for heroin averages 4 years. For fentanyl, it's closer to 1 year. And in many cases, it's months. So it's very, very fast. I think what it really points to is the fact that we need all of these messages simultaneously. We can't just be doing prevention and hope that works and then later move into health education and treatment and recovery. We have to have these conversations simultaneously so that people are aware of what the whole bundle looks like. So with youth, we're really looking at this rapid development of use disorder. We're looking at substances that are very potent and of unknown potency. So the overdose risk is very high. We absolutely should be doing overdose education and distributing naloxone. That will always have a small impact. You know, there's an emergency rescue medicine after an overdose has occurred. So primary prevention, I would argue really focusing on physical and emotional pain and building resiliency to those things in youth and their environments to reduce the emotional pain are going to be really important as well.
Thank you.
Thank you, Senator Crapo. Senator Stabenow.
Well, thank you. Thank you so much, Mr. Chairman. Thank you to all of you for really providing excellent testimony. And Mr. Vezem, speaking about the stigma and so much around addiction, people just say, well, just stop. And the reality is that this is physiological. I mean, it's about health, and your brain changes in its patterns and so on, as you know. And so this is something that involves treatment and support for people to be able to make the changes. So the rise of fentanyl has had a devastating impact, as we've been talking about this morning. It certainly had a devastating impact in Michigan. In 2023, we had about 3,000 Michiganders who died of a drug overdose, and 3 out of 4 of those related to fentanyl. So it's pretty scary what is happening right now. And it doesn't even come close to encapsulating the pain and the tragedy Michigan families have faced, as I know families have faced across the country. So we know that, among other things, this is an all-hands-on-deck moment for treatment, access to treatment. And in addition to what we have done moving forward in schools and the legislation we passed on safer communities, we have begun to transform behavioral health care in the community by fully funding community behavioral health clinics on the exact same model as federally qualified health clinics. So the FQHC model, full Medicaid reimbursement, prospective payment, and so on. We are now, we have 10 states, as hopefully you know, that are fully funded through Medicaid. In a couple of weeks, 2-3 weeks or so, the next 10 states will be announced. And then we will keep going and going until we have every state having the opportunity to have fully funded clinics, not just individuals, but the cost of the clinics, and it's so important. So I do want to just note that of the clinics now that we have, 82% of the behavioral health clinics offer at least one form of medication-assisted treatment for opioid use disorder, compared to 56% of other types of clinics. So these are comprehensive clinics. We want to see them all over the country, and anxious to work with all of you to do that. And so, Dr. Bannock-Green, I wondered, you talked about comprehensive community-based care in your testimony, and I turned to Senator Cantwell and said he's describing CCBHC's, Certified Community Behavioral Health Clinics, because that's what we're talking about: primary care, comprehensive care, addiction, and mental health services, whoever walks in the door, regardless of payment method and so on. But I wonder if you could speak a little bit more about community behavioral health clinics in terms of their role in closing the gap for opioid use disorders.
Thank you very much for the question. They are really providing a very important access point for many folks, and I think particularly folks with serious mental illness. And I think it's just a huge gap for those folks, very difficult for them to access care. And I think in particular, that's such a wonderful access point for them. And so I think that's a great thing that's happening there. It's a little bit, it overlaps and it's a little bit adjacent to the model that I'm describing, which is a bit different. Mm-hmm. We're sort of purposely not using a clinic-based model. We're really going into community settings, programs that are serving folks who are unhoused, really getting out into these communities community-based programs where folks already go. They already have relationships. So it's a bit different in that way. And there's also quite a bit of focus on infectious disease testing and treatment, which is very important as we're working towards hepatitis C elimination and the great medications we have for HIV. So there's definitely some parallels, but there are some distinctions as well.
Well, I think both are necessary. I think it's terrific what you're doing. I would love to see comprehensive model that involved under full funding the capacity for both, which is what we should be doing. And I would just say quickly, as my time runs up, that Mr. Vesna, you talked about access to recovery services for young people again. And as we look more, could you speak any more about school-based support for, we have health clinics in many places, but not necessarily mental health and addiction services, and sort of broadly, what more should we be doing?
Yeah, thank you so much. It's a really good question. I would start off by saying, like, we could educate teachers. You know, teachers spend a lot of time with our children, and they need to be equipped with the skills to identify and then properly refer kids to where they need to go. Now, you know, depending on the severity of the disorder, you know, it could be treated, eliminated inside the school, or they're going to need a referral out to, you know, a more specialized service. And so one thing that we see in Oregon is that there's not the comprehensive care for kids. And so they may have like some comorbidities with mental health and addiction, but there's not services to serve them. And so they end up in places where the providers don't have the tools for it. And so we need to bolster kind of the entire system of care and then intervene on kids in schools and get them to the appropriate level that's going to serve them best. Thank you.
Thank you so much. Thank you.
And thank you for your years of work in this area, Senator Stabenow, particularly with Senator Cornyn. Senator Grassley.
We hear this figure of 107,000 Americans dying from drug overdose. We learned just last week that more than 321,000 children have lost a parent to drug overdose in the past decade. I'm working to tackle the illegal production and distribution of this deadly drug like fentanyl from multiple directions through legislation to close loopholes, put pressure on the Biden administration to enforce the laws, hold adversaries like China accountable, and secure the southern border. As co-chair of the Senate Caucus on International Narcotics Control, I'm fighting to permanently classify fentanyl knockoffs. Throughout much of the opioid epidemic, drug kingpins have laced heroin and other drugs with a highly potent fentanyl. We must do more to proactively step up to stop the spread of that. Now, I'm going to follow on a question that Senator Crapo asked about Xylazine, and I'm going to ask Dr. Perrone and Mr. Vezina this question. First of all, I'm leading a bipartisan bill that recognizes this lethal threat and provides law enforcement with tools to combat it because it is a sedative and not an opioid. Its effects cannot be reversed by naloxone. That's a standard opioid overdose treatment. So to you two, what effects have you seen in Philadelphia and Oregon on drugs laced with Xylazine?
Thank you for that question. As I think I alluded to, it's a little bit confusing, but fentanyl and xylazine are always going together. So 99% of our exposures are fentanyl and xylazine. So when a patient is resuscitated from that kind of overdose with naloxone, they will wake up, they will restore breathing, and they will be revived. They may be sleepy for a couple of extra hours, and so the time to bring them to an emergency department, to support them, to have a peer like Mr. Vezina talk to them when they wake up is really valuable. There's been a lot of talk about antidotes for xylazine. I don't think that that's necessary. To make an analogy, there's medications like Valium and Xanax, which are benzodiazepines. They're not opioids. They make patients sleepy, but they don't stop people from breathing. We have an antidote for that, but we don't use it because it would immediately cause withdrawal, which might be life-threatening. So we have other antidotes for medications that cause sleep, but we don't use them. So really, I want to focus back on naloxone and fentanyl. Those are the deadly drivers of this epidemic. Fentanyl is the cause of people stopping breathing and dying. That's the 107,000 number, the 80,000 number. We need naloxone, and we need to focus on fentanyl. Xylazine has been a problem, but I think it's been a little bit overestimated relative to the huge impact that fentanyl continues to make.
Can you add anything to that, Mr. Bazina?
Yeah, thank you so much. What I would say from engaging people in the recovery process, most people that we work with are not targeting xylazine as their drug of choice. Like the doctor said, it's just included in the fentanyl. And what I've heard is it's a strategy to extend the legs of fentanyl. And what that means is to extend the effect. You know, fentanyl wears off really quickly. When I was using heroin, it would last me about 6 to 8 hours before I would start to go through withdrawals. With fentanyl, people are having to use every hour. And so I think it's a method to put xylazine in there to extend the effect. And so I think, you know, we need to focus on what can we do to help people discontinue fentanyl use. And again, medication-assisted treatment is probably one of the quickest and most efficacious ways to give people a chance to recover. Thank you.
To the same two of you, this. A few years ago, I suppose about 5 years ago, when I was chair here, I held a hearing that included a discussion on distinguishing between good treatment providers from bad treatment providers. Since then, the federal government has published best practices and guidelines for recovery providers. 5 years later, have we gotten better at weeding out good treatment providers from the bad ones? And if not, why are ineffective efforts and unaccountable treatment providers still in business, and what should be done about it?
The terms good and bad are difficult, but I would say that it's easy, if any of us had a child who was suffering from addiction, to think that you want to send them somewhere and get them off of everything. That's kind of the detox abstinence model. You may have friends or relatives who have gone to treatment for alcohol. That's an abstinence-based treatment model, and that's very effective for alcohol. For opioid use disorder, we desperately need these medications. Patients may succeed in becoming detoxed off of their opioids, but within days to weeks, they will have cravings and they will get back to that drug. The death rate after treatment in rehab facilities that don't offer medications are incredibly high. We know that the evidence basis supports methadone and buprenorphine, so we can incentivize only reimbursing places that offer these medications. And in addition, these places might offer the medications, but the patient alone may say, I don't want that, I don't want to substitute one drug for another. So we need to re-educate both treatment providers and patients in our communities, because there's such a push to abstinence that people just don't understand the evidence. And that's on us, clinicians, to continue to educate everyone. And it's an immediate instinct to think you don't want someone on any medication because you want them detoxed, but that's really just ineffective, and our evidence really suggests we desperately need medications. The long-acting injectable medications that persons would, get once a month would decrease their need to take a medication every day, and that really is supported as well.
The time of my colleague is expired. I do want to brag a little bit about Senator Grassley. He mentioned when he was chairman, some tall guy from Oregon, kind of obscure, was his ranking minority member, and Senator Grassley put together a very important report that looked into the whole question of tax-exempt entities helping to drive up opioid sales while downplaying the risk of opioid addiction. In all seriousness, I was pleased to be able to join you as the ranking minority member, and I ask unanimous consent to put Senator Grassley's important report into the record at this time. Without objection, so ordered. Senator Cantwell.
Thank you.
Thank you, Mr. Chairman, and thank you again to the witnesses. Dr. Green, from 2022 to 2023, Washington State saw a 34% increase in drug overdose deaths, which is the single highest increase in the United States. And that overdose is now the leading cause of accidental death in our state, outnumbering firearms and car crashes. of a report, drug overdose deaths in 2022, 70% involved synthetic opioids like fentanyl. So I definitely appreciated your opening statement about this model that Washington State did as a demonstration program. It became impressive with the number of results that I think you say are, well, we would have, it implies that if King County had those hubs in operation last year, the hubs could have saved over 600 lives. But you're saying there's been a 68% reduction, I think almost to Dr. Perrone's point you just made, that if you're not into the treatment, then you're not into a solution, basically, because it's such an addictive product. So one of the things that you discussed in your testimony was that low barrier, community-based models and that bundled care basically solved two problems. One, it got people into immediate treatment and got everybody else in the system, including the jails, to start this process with you. So basically, from the time of interaction with an individual, we now have them on a path to treatment. And then secondly, that bundling of care with those care navigators also provided a support for the system. My guess is, though, we don't have all the numbers from your results. We do have the information about how many lives are being saved. But my guess is that this also is cost saving. While it might sound that a bundled care payment is similar to what Senator Stabenow has done on community-based care, but you're literally saving dollars because you're not seeing the same people over and over again. You're definitely not seeing them in the emergency room. You're definitely not housing them in our jails. Could you speak to why this prospective payment model? I want to thank Senator Cassidy, though, before you comment, because he's agreed to help us demonstrate this also at the federal level. He's done great work on methadone oversight and trying to make sure that our clinic expansions on those issues. But could you talk about why this prospective payment system is so important?
Yeah, as you're hearing, we really need to allow people to access care rapidly and stay engaged. The process of recovery for alcohol and cannabis generally takes about a year, per research from John Kelly. For opioids and stimulants, it's about 3 years. And during that process of recovery, people are often returning to use. They may continue to use substances. So we need a place that people can start today and come back tomorrow no matter what. Just like the woman I was describing in our program earlier, she kept coming back because she was treated well. We had another client tell us, in previous treatment programs, when I relapsed, I didn't go back to treatment because I knew they were going to kick me out. But this time when I relapsed, I came back to care because I knew you weren't. I knew you were going to keep caring for me. So this model of care, this easy access no matter what, this open door, while people work on building their recovery over years, is really vital. And that takes the people and the place, and it takes the model of care. It's all of those things together. That stat, to me, is particularly exciting because we hear these statistics around a 50% or a 2/3 reduction in mortality. This was a population that was largely unhoused. This was a very vulnerable population. And these statistics, the way we did our analysis, is actually compared to other people who were in standard models of care and also got medications. So this reduction in mortality is really around high-risk populations getting this complete model of care. And that's what's really exciting and why we need to package those things together.
And how does it, we're basically, though, tying into existing infrastructure, which is also the cost savings of the model.
Right, and if you think about the cost savings, we're building on existing infrastructure. We're adding in things like nurse care managers and care navigators, which can be very difficult to bill for. There can be ways to bill for them in certain settings for certain types of conditions, but here, they need to be sort of universally folded into this bundle of services that are getting paid for, because they're the glue. They're the ones that are doing all of this face time. There's been multiple research studies that have shown prescribers will see a lot more patients. They'll start seeing any patients, and they'll see a lot more patients if they have these care supports, because it makes their job easier and the patients do better.
So it's also, you're just saying it's more streamlined. The whole system is
So
streamlined.
it's more streamlined. We even talked about savings, when you're actually able to intervene, test, and treat someone's infectious diseases. I mean, there's a lot of things that we're doing here that isn't just treating the opioid use disorder. Opioid use disorder almost never occurs in a vacuum. If it's also the reason that we're able to bring people in who have mental health issues, who have infectious disease issues, we're going to realize those cost savings. They're no longer need to be stealing in order to obtain their substances. So there's lots of different ways that we obtain those cost savings.
Thank you. Thank you, Mr. Chairman.
Thank you. I want to make sure everybody understands that the package that we produced in terms of what to do for kids and treatment and prevention did not happen by osmosis in 2022. Senator Cornyn was particularly valuable as it related to schools. I remember you and I talking about telemedicine provisions in terms of helping these kids, which largely came from Senator Carper. So, Senator Cornyn, you're on, and we thank you for your past effort to make sure that the Republican leadership was a key part of getting this done. It was a real breakthrough.
Well, thank you for that testimonial,
There you are.
Mr. Chairman.
Hope it doesn't hurt you.
Thank you all for being here and your contribution to our understanding of what is an extraordinarily complex problem. I remember H.L. Mencken is quoted as saying, for every complex problem, there's a simple solution that's simple, neat, and wrong. And so I think we need to look at the whole problem and not just parts of it. And we've tried to deal with the mental health aspects of it. And obviously, we're talking today about treatment issues. And it's important, I think, we treat the people who are suffering from these addictions with compassion. And Mr. Vezina, I would just want to congratulate you personally, not only for your personal recovery, but your example to show other people that it is possible. And that ought to be a source of hope and inspiration to others. But there is something called the law of supply and demand. And every time I go to Mexico City or somewhere like that and complain to the Mexican government about the drugs that come across the border, they say, well, if there wasn't a demand in the United States, then there wouldn't be a supply. What could we do to address demand? Nancy Reagan had an answer, just say no. But that, I don't think, it turned out all that well. So what could we do to address demand? Any of you?
Thank you for that question. I thought a lot about this in thinking through an answer. I think that, we have two problems. Right now, we have an abundant supply based on the price. The drug is incredibly cheap, and so it's everywhere. And that's actually driving some demand because they're putting fentanyl in other drugs, including stimulants and cocaine. And many of the patients that we see who are now becoming addicted are becoming addicted because unintentionally they were exposed to these substances. So a big supply problem. I think demand can be mediated primarily by medications for opioid use disorder for patients who already have a fentanyl dependence, as well as, I think, primary prevention, which is very complicated. Mrs. Reagan's Just Say No program is not effective. I think we need to trust adolescents to understand within their own communities how they want to take this on. For adolescent drug overdoses, if you look at who is overdosing, a third of the patients have a substance use disorder, a third of them have a mental health condition, and they're just self-medicating with what they think might be Xanax, and it contains fentanyl. And then a third are actually just overdoses that, are part of the inadvertent supply. So we need to take those patients, those adolescents, and learn from them and empower them to educate their own communities with obviously more guidance about primary prevention. So we need to listen to our teens and figure that out.
Well, in my much more limited experience talking to parents who are grieving the loss of their children, public awareness, both of the individual who consumes the drug unwittingly, maybe they think they're taking something else only to have it contaminated with fentanyl, but also parents and schools educating their students that it's, as the DEA's slogan goes, one pill can kill. But it strikes me that we can't just look at the treatment side. We have to also look at the supply side. And unfortunately, we've seen a tsunami of human beings coming across the southern border, which is actually part of the business model of the cartels. They get rich for every person they can smuggle across the border. And then when the Border Patrol are occupied with processing migrants, maybe unaccompanied children and the like, then here come the drugs that killed 108,000 Americans last year alone. I was just looking at the statistics. In the last 3 years, about 200,000 Americans have lost their lives due to fentanyl poisoning. And it seems to me we've been extraordinarily naive and unsuccessful in dealing with the supply side, primarily because our border is not controlled. And if you go to places like Colombia, for example, typically the source of cocaine or the heroin that comes from Mexico and elsewhere, they say that their market share of those drugs is actually going down for the very reason that you mentioned, doctor, is because fentanyl is so cheap. You don't have to grow a plant. You don't have to process it. You just mix up the precursors in your sink or where else, make it look like a Xanax or Percocet, and there you go. So I think we have to look at the supply, which also includes interdiction of those drugs coming across. I'm not suggesting that's the only answer. Obviously, it's a very complex set of circumstances, but to just look at the treatment without the supply, I think is to not address the whole problem. Thank you, Mr. Chairman.
Senator Cornyn, Senator Carper.
Thanks, Mr. Chairman. And Mr. Chairman, thank you. Our thanks to you and our ranking member for pulling us together for this important hearing. Sometimes when our witnesses come before us, they actually bring a member of their family. And sometimes we actually ask them to introduce members of their family. But I'm not going to do that today. But it's pretty easy, Dr. Perrone, to find the one who, because she looks just like you. And she's sitting right behind you. So we're watching to see if her lips move when you speak. We'll see who's calling shots here. But our welcome to her and any other family members who might be here today. Welcome. The substance use commonly as we know, usually oftentimes begins during adolescence and compromises the well-being, compromises the safety and the development of our young people. When it comes to health care, I long believe that we got to meet people where they are. And for our youth, that is in schools in many cases. During the time I was privileged to serve as governor for 8 years, before I came here 22 years ago, I was proud to put a school nurse in every Delaware public school and a wellness center in just about every high school in Delaware. Mr. Xylazine, you stated in your testimony that people with substance use disorders can recover when they are provided the tools to do so. I think that's what you said. And I would just ask Mr. Xylazine, could you please speak further to the importance of school-based supports in providing adolescents the tools they need for the prevention and treatment of opioid use disorder?
Yeah, thank you so much. I would just reiterate again that we need to prevent it from happening in the first place. And from my limited understanding, I don't run any prevention programs, but I do work with a bunch of prevention advocates in Oregon, and they always make sure I say primary prevention, not preventing overdoses. They don't have necessarily a reimbursable service model like treatment does. And so it's hard for them to get their services up and running. And so I would, ask this committee to figure out a way to fund primary prevention for organizations to go out and educate our kids and build resilience in our kids. There's one private organization that I work with that I'm on the board of called A Song for Charlie. And it's led by two parents who lost their son to fentanyl. And they've done incredible work with educating kids around the dangers of fentanyl. I recall a study before around the naivety of children with fentanyl where they thought cigarettes were more hazardous than fentanyl, and that's a big problem. And so we need to educate our kids and give them the tools not to use. And then again, when they do develop the symptoms of a substance use disorder, we have to be able to intervene and then get them to the services that are going to best fit them. And right now, at least in Oregon, and I assume it's like this across the rest of the nation, there is not an infrastructure for adolescent care. And from my understanding on the Medicaid side, it's two parts. One's regulatory and administrative burdens, and the other part is low reimbursement rates for care. And those two things disincentivize individuals like myself who would run treatment programs from opening up care for kids. Thank you.
Okay, thank you. I'm going to follow up my question I just gave you with a question for the record, and appreciate your comments there. A question on workforce readiness. In recent months, not only has our healthcare system in Delaware seen a greater number of patients being treated for suspected overdoses, but there's also been a significant increase in the severity of the effects of overdoses. This severity is reflected in a greater percentage of overdose patients needing a higher level of care, including intubation and required admission to intensive care units. Dr. Prum, my question is, can you speak to why we're seeing such an increase in the severity of the effects of overdoses? How can we work together to ensure that our first responders are best equipped to address this growing crisis?
Thank you for that question. The question was, why are we seeing an increase in serious consequences of overdose? And I think that goes back to these mixed substances. So a patient who overdoses on a typical bag of what somebody thinks is fentanyl now contains 3 or 4 other drugs, including Xylazine, especially in Delaware, where the radius of Xylazine concentration certainly extends to the Delaware area. So patients may be quite sleepy after an overdose, despite the fact that they got some naloxone, but their respirations or their breathing might have been adequately restored. But in the setting of continued sleepiness, or somnolence as we call it, they may undergo intubation. And once they have intubation, meaning that they're on life support, then they end up in an ICU, because that's the only place in a hospital where we can manage people on a ventilator. They might be able to not be intubated and be managed in an emergency department, but frankly, we have such boarding issues in the emergency department. We're filled to the gills, 100 people in the waiting room, so sometimes moving a patient who might be critical for the emergency department to manage back to the ICU because they're intubated is a good strategy, because the emergency department needs to manage new patients coming in. And so I think for EMS, we need to continue to advise them to use naloxone. They have the airway management skills, and when a patient comes to the hospital, we could probably manage some of them very closely without intubation and allow them to wake up on their own. Once you're on a ventilator, we actually often need to give you additional sleepy medications to keep you on the ventilator, so it's a little counterintuitive. But we need new research looking at these mixed substance overdoses and the best way to manage them.
Good. Thank you very much.
I thank my colleague. Mr. Vesna, very important point about getting the architecture right for getting information to kids and schools and the like. We're beginning to build it. I've been getting out and talking about the benefits of the 2022 law in terms of Medicaid. But since you're here and you're doing so well, we're going to get you involved in building out that architecture too, because I think you've said it very well. Senator Cassidy.
Dr. Perrone. In my medical practice, I'm a doc too. My medical practice, I worked with in a hospital for the uninsured and the poorly insured, which is a euphemism for Medicaid. And I'm recognizing that Medicaid, although coverage, oftentimes pays so little that, frankly, people don't take it. So, knowing that Medicaid is financing a lot of these treatment programs, but as a poor payer, your business model somehow has to accommodate for that. It might be a community health center, et cetera. If you look across our 51 jurisdictions, what is the kind of uptake? Relate to me on some sort of a graph. If this is Medicaid and this is the number of treatment programs relative to population, how good is Medicaid doing in terms of encouraging people to provide these programs?
Thank you for that question. We work in a model where we're primarily, all of our patients are Medicaid or no insurance, so we rapidly get them on Medicaid. And fortunately, in Pennsylvania, we do have pretty rapid access to Medicaid. Whether or not that reimbursement is sufficient, it certainly is not. I work in an academic medical center where, the mission pays for
So you have less, you have some sort of subsidy for good human work.
Yes.
Now,
yes.
that said, though, my question is not on the particular, but rather on the statistical. If I were to look at, the average among states on a per capita basis, relative, and the capita is the number of people who need treatment, how much is, and knowing that many of these are Medicaid patients, how well is Medicaid doing in terms of financing this care?
That's a difficult question for me to answer. I could say Medicaid is the largest purchaser of addiction services in the country, but I don't know what the gap is in terms of people who aren't getting appropriate addiction care.
Can you just speak in general then about what is the, okay, let me just kind of drop that. Mr. Vincina, again, in my medical practice, I used to treat patients from jails. I used to go into prisons, so I'm aware of all this. I am aware that somebody who is currently booked into jail loses Medicaid benefits before being adjudicated. And so they may be said not guilty, but they've still lost their Medicaid, and they have to go through the whole rigmarole to get back onto Medicaid. Now, something that we're working on in this committee, Senator Wyden and I, two bills. One, the due process, which would allow 7 days of coverage or 14 days, depending on the version, of somebody with substance abuse to continue on Medicaid once put into a jail, and then reentry, which would allow the enrollment into Medicaid 30 days prior to discharge from a prison. So any comments from your kind of like living the experience, how this might help somebody either initiate and continue therapy once on the outside, they aid in that transition, or else never lose Medicaid and so they never lose the coverage that they would like to have?
Yeah, thank you so much. In the most general of terms, I would say, jail serves as a rehabilitation place, right?
It serves as a rehabilitation?
Right, and so we would want the services in the jail, however we pay for them, that would give people rehabilitative services. And knowing that the majority of people in jail have a substance use issue, and a lot of times that drove their other criminal behavior, we would want to address that first and foremost. And so in the county jail systems, a person loses Medicaid and then the jail has to pay for the services. And I'm not an expert on the criminal justice budget, but I feel like they don't have the money to pay for adequate services. And so leveraging Medicaid match for those behavioral health services would be ideal from a cost savings perspective. And then in prisons, I've been working with some guys in prison, and from what I understand, adults in custody aren't eligible for treatment until 6 months post before they leave. And that doesn't make a lot of sense to me, because you think you would want to treat them and get them support right when they got there so that they could begin.
Now, hang on. But if somebody is in a prison, therefore they are at least incarcerated for a year or more.
Right.
Theoretically, although we know there's lots of contraband, they would not have access. Granted, as Dr. Perrone says, that doesn't mean that they won't go back, but in prison they'll have less opportunity to go back.
Yeah, you would think that, but it's just not the case. And so what I would say is that we'd want them to have access to treatment.
Do you know if we
recovery
have
services
data
right away.
on the degree of fentanyl overdose within prisons?
I'm not able to answer that question today, but I will say that it has been a problem in Multnomah County that I'm aware of, to the point where there's a passing of the torch of who's going to help people who are addicted. And so jails may be less hesitant to take people if they have a risk of overdose.
I'm out of time. Dr. Perrone, I had a question for you, but instead I have kind of a critique. One of my favorite employees is sitting right behind you. You stole him from me. I'll forgive you for that, only because I wanted him to have great opportunity. But again, thank you for your good work. And Mandar, great to see you, man. I yield.
Thank you, Senator Cassidy. Our work is going to continue in this area relating to prisons, and particularly because we've got some exceptional sheriffs and law enforcement officials in Southern Oregon working with their state representative, Pam Marsh, on exactly the questions that you're raising about this whole kind of proposition, because the nuts and bolts of this, we're getting the Medicaid match and all these related issues. You're going to be a busy guy, Mr. Vesna, because this committee is going to keep you as an Oregonian active on these issues, and look forward to it. Senator Bennett.
Thank you, Mr. Chairman. Thank you to you and the ranking member for having the hearing. Thank you all for being here today, taking time out of your schedule to be here. Let's see, Dr. Benta Green, I'm not going to pick on you, but I have a question for you. The opioid crisis continues to devastate Colorado communities, especially our kids. Last year, Colorado tied New Mexico for the second highest number of fentanyl pill seizures in the country, and Colorado has the second highest youth overdose rate, more than double the national average for kids between 14 and 18. Today in Colorado, and I would say across the country, students are petitioning their school boards to allow school nurses to provide naloxone in their office, because without it, their friends might die before an ambulance arrives. I once was the superintendent of schools in Denver. It wasn't that long ago. And that's not what kids had to spend their time doing, but it is what they're spending their time doing today. When I heard a student had died back then, and it would happen from time to time when I was superintendent, I used to ask whether that child had been in a car accident or whether she was dying of cancer. But now when I hear a child has died, the question that I ask myself is, did they die from guns? Did they die from suicide? Or was it a fentanyl overdose? That, like tree rings, you can, at least I can time that there was something very different about the world when I was being run by the Denver Public Schools 15 years ago versus today, and especially for our kids. Historically, treatment for substance use disorder has focused on kids. It's clear to me that we need to do more to address teen substance abuse. So, Dr. Banta-Green, could you identify gaps in treatment or services for young users in this country, and how do we recalibrate our approach, particularly under the Medicaid program, to account for the rise in youth substance use disorder?
Thank you for the complex question. A few things I'll note on that. So in terms of schools, one, I understand why we want to work in schools. We know where many youth are, and that's an important place to do this work. And we need to do this work in schools and support them. We, of course, need to look at the social determinants of health upstream of that, out in the community. How do we support those families so that they can have their own resiliency, so they can identify and address physical and emotional pain? I think about there's this idea in schools, and I've done many trainings with school nurses about naloxone. Naloxone's great. Naloxone's the floor of what we should be doing. Naloxone is the gateway drug to talking about opioid use and opioid use disorder. Those same school nurses have to know that this is a treatable medical condition and that buprenorphine will reduce mortality by over 50%. It is appropriate and authorized for adolescents. So it absolutely should be being used. We run a learning collaborative once a month for adolescent medicine providers around treating opioid use disorder. We have about 30 to 40 prescribers showing up from across our state. So that's very important. And then I just can't say enough about what Dr. Perrone said is, you think about these different time horizons. Okay, they have opioid use disorder. We know what to do. But why are they using opioids? So in the moment, they're often using it in the context, sure, of peer pressure, but what we find often is really in the context for the same reason that adults are using medications, which is pain, anxiety, and sleep problems. And identifying those and having those resources in schools is going to be very, very important. And then there's the upstream factors as well. But those are just a couple of things to think about with adolescents, is that we have to, again, be thinking about what are all of the different opportunities to intervene.
We're facing as a country. Youth suicide is at an all-time high. Children's emergency room visits for mental health have increased by 140% over the last 5 years. In 2021, 40% of Colorado's high school students reported persistent sadness or hopelessness. To Dr. Banta-Green's point, Dr. Perrone's point, Colorado psychologists tell me in all their years of practice, nothing has affected kids the way that social media has affected kids. Parents and teachers tell me they feel absolutely hopeless to address it. And I don't think that we can lay this all at the feet. But when people ask me what's different about schools today than when I was there, the answer is mental health, mental health, mental health. And you can chart it back to when everybody ended up with one of these phones in their hand, and social media. One of the leading law enforcement officials in America told me recently that social media is the last mile for every fentanyl and meth death in America. Dr. Heron, could you elaborate on the intersection between the mental health crisis and the increasing substance use among our youth that Dr. Banta-Green was talking about? I'm going to stop there because I'm out of time. So if you could just take a second, and then I'll turn it back over to the
Thank you for the question, Senator. We see, the intersection between mental health and substance use disorders, is the primary focus of someone like me as an addiction psychiatrist. The majority of individuals in either treatment setting are contending with the other type of disorder as well. So if you look among mental health treatment, we see a large group of people with substance use disorders and vice versa. Both primary prevention, where we teach people to recognize that the feelings that they're experiencing, the anxiety, the pain, is an illness, and there are treatments available, are essential, and also pushing those services into school-based mental health treatment models, into pediatrician offices, into family medicine offices, so that there's a recognition and ability to treat those things before they get into adulthood, before they have more exposure to substance use, is really essential to helping to impact the crisis.
Thank you. Mr. Chairman, thank you. I apologize for going over.
Well, I want to apologize to our colleagues because we're doing some juggling here. If we could, let's go with Senator Barrasso and Senator Brown. Nothing is going to get in the way of that order. Senator Barrasso.
Thanks so much, Mr. Chairman. And this is a critically important hearing. I'm so glad you're calling this. I just heard from Dr. Cassidy, a physician as well as a member of the committee. I'm a physician as well as a member of the committee, both concerned, as we all are, about the health and safety of our nation. Truly alarmed by the fentanyl crisis facing our nation. Clearly, nothing like that existed when I was practicing medicine. It's everywhere. No community is spared. A lethal dose is the equivalent of just a few grains of salt. Across the country, the number of deaths has been skyrocketing. My home state of Wyoming, you wouldn't think that it'd be a problem there. We've had 81 opioid-related overdose deaths this past year. It's doubled the number from 5 years ago. Completely unacceptable. It's touching every community across our nation. You got mothers, fathers, brothers, sisters, all losing family members. I hear about it all around the state. Since President Biden took office, nearly 10 million illegal immigrants have flooded into our nation. And Senator Grassley touched on this a little earlier today. 77,000 pounds of fentanyl confiscated at the border over that time. You don't know how much got through, but you can imagine just based on the statistics and the deaths, the number is high. Whether it's from China or Mexico, the transnational criminal networks that are producing, transporting, and marketing these drugs are poisoning our country. Our Border Patrol agents are supposed to be our first line of defense in apprehending the drug smugglers. They can't get their job done to the level that it needs to be done. They're being forced, I believe, by this administration to deal with unaccompanied minors, asylum seekers who are surging across the border, which is making an increased opportunity for the criminal cartels to get more drugs across. So, Mr. Avenzi, I've read your story, hear what you have to say. I really appreciate your ability to be here to speak on the substance use disorder care, because that's what we're looking for. Care is needed now more than ever. Today, you've spoken about the challenges that folks in recovery face when they don't receive a full continuum of services. There's not like one silver bullet on this. You need the whole thing. Your experience as someone in recovery, someone providing collaborative care, says you need a network. You need mental health counseling, substance use counseling, peer support, case management, medication-assisted treatment, all of those things. So given the frontier nature of my home state of Wyoming, people are spread out. You don't have all of those services available everywhere. There are only 2 towns with a population that can support this level that you've described of the specialty care, even less availability for youth-focused programs like yours. Are there existing programs, either state or federal, that you're aware of that can help in rural communities where you don't have that full continuum, even though we know that's the best treatment?
Yeah, thank you so much. From what I can tell you in Oregon, telehealth services have been able to meet some of the gap, so figuring out ways to fund telehealth services. There's also some restrictions and kind of geographic capacity that providers run up against when they're not reimbursed for that. Sometimes there's standard reimbursement rates for care that are really designed for when people walk into the office, and they don't take into consideration some of the other costs, like some of the things that we do in Clackamas County is we have to drive all over the place because it's part urban and part rural. And so we have to either fundraise money or get additional grant costs and stuff like that to cover our mileage for people to drive out and meet people where they're at. So that's a couple things I could think of.
Dr. Barone, a quick question. You know, February this year, the DEA reported on regions of the U.S. being targeted by the Mexican drug cartels. And I live in one of those regions in Wyoming. They found that the cartels are targeting states further away from the border. Highest area of focus are Native American reservations they talk about in those states. Certainly that's the situation in Wyoming. Our Eastern Shoshone and Northern Arapaho, they live on the Wind River Reservation, larger than the state of Connecticut. I mean, we're talking about a big geographic area and low population. It continues to experience one of the highest drug overdose deaths in the state. Deeply concerned about the cartels that are targeting our Native American populations. A lot of them has to do with the fact that the size of the geography and the smaller number of people make it an area where they can really focus. You know, can the federal government do things? How can we best respond from the federal government level to counter the efforts by the cartels?
Thank you, Mr. Barrasso, for that question. I mean, in terms of supporting patient populations in rural areas, I think telehealth can give more rapid access to treatment. I think you're going to need some on-site care in the Indian Health Service in order to, provide support for this population. In terms of, around the country, other groups have targeted vulnerable populations, like the drug companies that precipitated a lot of this, have also targeted populations in Appalachia and other places that started the demand for opioids. So we have a lot of work to do to unwind a lot of these things, but I think resources and reimbursement for services on site would be really important, and perhaps expanding the Native American Health Services with a focus on integrated care models there would be helpful.
It seems to me, this is my last statement, Mr. Chairman, that until we secure the border and protect Americans, we're not going to be able to get to the bottom root of the fentanyl problem.
Time of my colleagues expired. Today we're focusing on the bipartisan efforts on the health aspects of fentanyl. Several of my colleagues have mentioned the whole supply issue. If we're talking about supply and fighting the cartels, that gentleman over there, Senator Brown of Ohio, has written the Fighting Fentanyl bill, the FEND Act. It's going to make a big difference on supply. Senator Brown.
Thank you, Mr. Chairman. Thanks for mentioning that at the beginning of the hearing, too. 400 people die every month in my state, a relatively large state. The problem serious, of course. I was in Toledo not too long ago talking to the former husband of a woman who was an auto worker at the Jeep Cherokee plant, assembly plant in Toledo, and she had a workplace injury and she started taking opioids and she developed addiction. She died of some kind of fentanyl poisoning. Not sure where it came from. We know that those are human stories, not just statistics. Obviously, as Mr. Vesna, you certainly know, and as the chairman said, after fighting for a year, Congress passed my Bipartisan Fentanyl Act, which focuses on targeting and sanctioning the precursor chemical makers in China and the manufacturer, the cartels in Mexico that put this stuff together, cracking down obviously on the supply. And at that level, going after where the big money is really important. But of course, it's an all, as the chairman said, it's an all the above approach. Let me start with this, Mr. Vesna. You discussed in your testimony the importance of prioritizing interventions for youth and young adults to prevent and treat substance use disorders. Peer support workers are people that have a lived experience with a substance use disorder or mental health condition and work with people in recovery. These services have been shown to be effective in helping people recover. Mr. Vesna, as communities work to implement various peer support models for addiction, what are the biggest barriers in their doing that?
Yeah, thank you so much for the question. Certification can be a barrier. Sometimes state license certification or licensed behavioral health providers have really stringent background checks, and a lot of people like myself in recovery have criminal histories, and so that's a barrier that we've faced. Additionally, reimbursement rate models that are commensurate with the actual activities that peers do. You could look at that. For example, pre-treatment engagement. So this would be before somebody got an assessment and a prescription to care. allowing peers like myself to go out and engage people and motivate them to seek recovery. That's something that you could look at. And then I do not think it's within the jurisdiction of this committee, but from my limited understanding, there's issues with reimbursing peers on the commercial market as well.
And Medicaid clearly has been a lifeline. I was in Cincinnati at the Talbert House, and sort of an iconic treatment program and center for 60 years now. And I was sitting with a man and his probably 30-year-old daughter, and he put his hand on her arm and said, she's alive today because of Talbert House where we were and because of Medicaid. And we all know that. How important is Medicaid in your mind when it comes to patients accessing treatment services?
Oh, it's incredibly important. You know, just for myself, before the expansion of Medicaid, there was a lottery system, and I was trying to get into treatment, but I didn't get selected for the lottery. And so I had to wait, and they had to prioritize other populations aside from me. But after Medicaid expansion, I was able to get into treatment immediately anytime I sought it, for the most part, in Oregon.
And there's obviously the question of prior authorization, which is in far too many cases sort of the overuse of prior authorization, a burdensome process that requires an insurance plan to approve services before a patient can receive them. Dr. Perron, how important is it for a patient who's ready to get started with treatment to be able to access it immediately and in the face of the problems we have prior authorization? Talk about that, if you would, for a moment.
Yes, thank you. Our care model has been built on same-day treatment. So when a patient comes for care, we want to start them on medications immediately. Because I work in the emergency department, prior authorization is not necessary for me to give that medication, but for me to prescribe it and for the patient ultimately to get it filled. That was a big barrier. In Pennsylvania, they did get rid of prior authorizations for the initiation of buprenorphine a few years ago. They recently also allowed us to write for higher doses, which have been necessary in the fentanyl era, and which also required prior authorizations until recently. So
talk about that, why you write for higher doses.
So because, as Mr. Vezina explained, the use of heroin was often about 4 times a day because it lasted 4 or 5 hours. Fentanyl lasts a couple of hours, so people are using 8 and 10 times a day. The degree of opioid dependence that people have developed from fentanyl rivals anything I've ever seen, and tremendous need for medications at much higher doses to combat that, both methadone and Suboxone or buprenorphine. So now we need to prescribe higher doses. The higher doses were restricted by prior authorizations, but now that process has actually been changed in Pennsylvania, but probably not in a lot of other states. So we can prescribe 24 milligrams instead of 16 milligrams a day because that's what our patients need.
Thank you for the work you do in Senator Casey's state. Thanks.
Thank you, Senator Brown. Here's where we are. First, with respect to the comments Senator Brown has made, I think this kind of highlights where we are in this debate. We're going to have to tackle the supply issue, and that's why Senator Brown's approach under the FEND Act is going after the cartels. I strongly support that effort. And we've got to come back and deal with the medication issue, which is why he talked about the prior authorization. Those two pieces are critical as we sort out this puzzle, and I thank my colleague for doing it. Here's where we are. I'm going to have to run and vote. Senator Crapo will run this till we get back. I think next in the queue is Senator Whitehouse, but Senator Crapo will run this, and we're getting close, colleagues, to wrapping this up. I have an additional question. Senator Crapo may, but we're getting close, so if the word can go out that we're almost there, we're getting ready to finish. Senator Crapo will just call Senator Whitehouse.
Thank you, Chairman.
Thanks.
I heard my colleagues' comments about the need for added border protection against fentanyl, and it's timely to hear that because we all have the chance today to vote on a bipartisan border measure that would add unprecedented levels of detection and enforcement at the border. So it will be interesting to cross-reference the comments and the votes. Just a word on Rhode Island. I'm pretty proud of what we've done in this space. We were early leaders on getting medication-assisted treatment into our correctional institution. That reduced opioid fatalities by over 60%. Just that one measure. And it's expanded beyond that. I am really proud of our police chiefs in multiple police departments who have peer recovery specialists, recovery coaches, recovery follow-up after the night sheets come in, social workers engaging with the police departments. It's really been pretty outstanding. Some of our fire departments are turn up, ask for treatment, and we'll get you in a treatment site. Some states had difficulty making that work. We made it work. We've got the 988 program operating with a group called Behavioral Health BH Link, so that if you call, you're immediately on the phone to get the resources you need, which can include vans that go to you. So there is a lot going on. I want to really applaud the Rhode Island treatment and recovery community, which has stepped up to this in wonderful ways. And the behavioral health centers that have been Senator Stabenow talked about are very often being set up in Rhode Island in conjunction with the treatment and recovery facilities that are already there. So we even have a safe injection site that is doing full wraparound services to try to get people off of their addiction as quickly as possible. So there is a lot going on. I think, as all the witnesses know, this is an ecosystem that is being built piece by piece, and we need to build it out more robustly and improve the coordination. But I've been really impressed with what I've heard from all of you today, and very, very grateful for your work and your focus. Dr. Perrone, one of the things that we are going to have to face up to is that at the end of the year, the COVID telehealth authorization for opioid treatment expires. And I have a bill that I hope will prevent that from happening. We have to get it passed. In plain words, is there any upside to letting that telehealth authorization expire?
Thank you for that question. I also would applaud the Rhode Island Department of Health and many innovations. As COVID started, I was actually on the phone with my colleague at Rhode Island Department of Health as we rapidly pivoted to a telehealth strategy. And I would say, no, we definitely want the telehealth reimbursement parity, the telehealth options that we have that were rapidly innovated. I'd like to applaud all the people involved in allowing us to provide telehealth during COVID as swiftly as it was made. And we need to sustain that regulation because it's critical. We've treated 2,000 patients. I'm sure Rhode Island has treated a large proportion of people via telehealth. Various other programs have popped up around the country, but we could create a telehealth network that would be less expensive than a lot of other on-site care, just for care retention and gaps and people leaving carceral settings. So telehealth could be widely used more than it is and save a lot of lives. Thank you.
In my last 30 seconds, I'll add one additional observation that I've heard repeatedly out of the recovery and treatment community in Rhode Island, in which we had a witness here in the Finance Committee the other day also volunteer, which is that the professionals who are dealing with people in recovery not only saw telehealth as an important functional advantage in terms of people being able to meet their appointments and have the communications that they needed to have, but that the actual substantive content of the engagement improved because people felt more comfortable being able to engage telehealth from home, not have to drive across town, not have to wait in the waiting room, not have to fill out the stupid clipboard, not have to go into somebody's office, but actually be able to engage from a place where they felt considerable personal comfort. So I offer that closing thought, and thank you very much.
Thank you. Senator Hassan.
Thank you, Senator Crapo, and thanks to you and the chair for holding this hearing. To all of our witnesses, thank you not only for being here, but for the work that you do. I just wanted to start, Senator Crapo, commenting because we were both part of the bipartisan congressional delegation that traveled to China, and I know you talked about that a bit. We really pushed Chinese President Xi to stop illegal fentanyl precursors from flowing out of China. China has said it would work with the United States, and that was a really good first step. But we need to see stronger actions from the Chinese government to disrupt drug trafficking that empowers international cartels. And while we continue to work to stem the flow of fentanyl into our own country, and I would echo Senator Whitehouse, we are voting on a bill this afternoon that would provide extremely strong protections at the border, strengthen our border, including strengthening the way we combat fentanyl at the border. And I hope my colleagues will join us for voting for that bipartisan bill. But we also need to continue to seek progress on treating opioid addiction. So I wanted to ask all of you, because there's been a line of questions about medication-assisted treatment, the importance of Medicaid coverage to help people get that treatment. Senator Brown and Senator Wyden both talked about it. Dr. Perone, you talked about some of the barriers to getting people access to medication-assisted treatment when they need it, at the place they need it. Is there anything that hasn't been mentioned that's a barrier, whether it's through Medicaid or elsewhere, to getting that kind of medication-assisted treatment? And I'll start with Dr. Perone, and we'll just go right down.
I think we subtly mentioned stigma. People are embarrassed. They're terrified. They have been treated poorly in healthcare settings. So back to telehealth, that is one of the reasons why people feel more comfortable initiating care over the phone, meeting a provider over the phone, and then knowing that either in a peer-led model, they would see someone else as a familiar face when they go into treatment. So I'll just stop there and let my other colleagues
That'd be
talk.
helpful. Thank you. Just time is limited.
I'll just mention a couple of quick things on the same theme of stigma. We know that approximately half of physicians still think of medications for opioid use disorder as a replacement in a negative way for addiction. So that's a very important factor that we need to be thinking about. And we really need to educate the general public that opioid use disorder is a treatable medical condition, and medications are the most evidence-based interventions we have. And very importantly, they don't just reduce mortality, but they actually support recovery. I've had people who were on Suboxone and cycled on and off it because they thought while they were still on it, they were still an addict. And the idea that you can be in recovery and be on medications is important for everybody to know, because if the family isn't supportive, those folks may not start or stay on medications.
Thank you.
Thank you for the question. I'll just underscore again the importance of low barrier access to treatment. People working in integrated care settings having the ability to receive patients at the moment that they're ready to enter care. Addiction is inarguably a disease. There is also a behavioral component to this illness. And we need to be able to catch and welcome patients into care at the time that they are ready to do it and have no wrong door. So if you're with your primary care provider, your dentist, your psychiatrist, that anyone is able to do that. I'll also add the fentanyl crisis in particular has increased the need for higher doses of medication. That also means that not everyone can adequately be treated with buprenorphine. Buprenorphine was a revolution in providing care by prescription, so people didn't have to travel to opioid treatment programs. I know, Senator, you are well aware and have some legislation about expanding access to methadone, but that's a serious geographic concern where there are entire states, hours of travel necessary for people to be able to engage in methadone under the current treatment structure.
And would it be, just to follow up on that, would it be safe to expand methadone treatment beyond certified methadone clinics? I think we have now evidence because of the pandemic that says that it is.
Absolutely. It shouldn't be more difficult to access treatment for a substance use disorder than it is to get prescriptions for opioids.
Right. Thank you.
Yeah, and I would just say it should be easier to get medications that treat opioid use disorder than to purchase drugs on the street. That seems like a no-brainer. One thing that we run up against is there's a need for education around MAT for adolescents. Some people believe that you cannot prescribe adolescents MAT. And then when we do have those providers, there's a lack of demand because people aren't educated in the fact that, hey, I have an addiction, or my kid has an addiction, and oh, hey, this is treatable, and here's an intervention that can work. And then something that I fought really hard for when I was student body president of Portland Community College was to educate allied health professionals and health professionals in general around substance use disorder and recovery. And so we need to do a better job of educating our healthcare
I
system.
appreciate that. One last thing, Mr. Chair. First of all, Senator Markey and I do have a bipartisan bill on modernizing opioid treatment that would expand access to methadone outside of methadone clinics. And also, we need to do a lot more to understand and encourage doctors to do appropriate MAT for pregnant women who are suffering from addiction as well. Thank you. Thank you all for your testimony.
Thank you, Senator Hassan, and I appreciate your mentioning the fact that we were able to meet with President Xi in person in China and talk about this issue, and you are leading on that, so I congratulate you on that. Senator Cortez Masto.
Thank you, Mr. Chair, and thank you to the panelists. I know it's been a long morning. You're probably getting asked the same questions over and over and over again, but I thank you because the advocacy and your experience, it matters to help us address here, at least at the federal level, what we can do to continue to address the fentanyl crisis that we see in this country. Can I ask this? There's been a lot of conversation about integrating addiction treatment with mainstream healthcare. I think that's where we need to go for so many reasons. That's so important for us to do it. And at the federal level, we're working to try to incentivize that movement. I will say, and I appreciate Senator Cornyn and I, we introduced the Complete Care Act, which actually increased Medicare payments to primary care doctors who incorporate behavioral health into their practice. That's the first step of incentivizing. I thank my colleagues for helping us advance this out of the committee, but more needs to be done. The continuum of care, there's gaps in it. We all know that. And my focus is how do we address those gaps? Because everybody plays a role, a key role here at the end of the day. And so, Dr. Herron, can I start with you? Because FQHCs, there's some in my state as well. And despite being well suited for integrated care models, the implementation, however, is challenging for FQHC. Can you talk a little bit about that, what those challenges are and what we need to be aware of so that we can help overcome those challenges for those clinics?
Thank you for the question. There are a variety of challenges. Some come at the reimbursement level where there is difficulty for primary care providers, for example, billing behavioral health codes and not being able to get reimbursement for a depression visit versus a diabetes visit. There's also challenges in education of the workforce, and so putting training into primary care residency programs. I'm an addiction doctor and an addiction medicine specialist, so that's a lot of people that started in other fields and then received additional training in addiction. But really putting that type of education into medical school curriculum and to residency programs so that people are able to have a base foundation of how to approach mental health. There's always going to be a need for specialty treatment. Some people will need inpatient treatment. Some people will need higher levels of care. Some people will need, residential sober living and things like that. But not everyone does. And so being able to start at the level of outpatient practice and to help the people that are able to be served in those settings actually also helps to reduce stigma and reduce healthcare costs. People don't necessarily need to see a specialist for everything. And just like we can do, basic hypertension care or basic high cholesterol treatment, and only some people need to see a cardiologist, really focusing those efforts on expanding primary care workforce and recognition help a lot. FQHCs, vary, and I'm fortunate to be in New York where we do have a lot of flexibilities and encouragement around this, but there are also a lot of regulatory hurdles. I'm in a state that has multiple different regulatory agencies for addiction versus mental health versus primary care services, and so also integrating those and figuring out the reimbursement, the licensure, the regulatory oversight of all the different streams of services, I think have been daunting for some communities and difficult for some health centers to implement.
So it's not just at the federal level, it's the state and local. The state is a key partner here when we're trying to build out this continuum of care.
Absolutely.
Right? And there's barriers to some extent there, maybe not intentional, but they do exist.
Yeah, absolutely. And I mentioned earlier also the same-day billing restrictions that are, again, a state decision. My understanding is that they're permissible under federal law, but up to the states to decide to do that or not. I am in a state that has same-day billing restrictions, and so we have, despite having co-located care, I'm fortunate as an FQHC to be able to provide care even if I can't be reimbursed for it. And we receive funding from other sources to help support that. But not everyone can afford to do that, and so people can be in centers that offer both types of things, but not actually be able to access different services on a day and then have to come back, which is going to just decrease likelihood of being in care.
And I only have 28 seconds left, but I'm curious just for the panel, anything you want us to hear that we haven't talked about today, that just strikes you as important that you want us to take away from this conversation? Or we've covered everything?
Yeah, the last thing I'd just like to say is that, there's over 20 million people in America who are in recovery. And in my early recovery, people would say stuff to me like, I'm unique or one of a kind. But, not everybody's vocal about their recovery like me. And so I just want the public to know that if we fund services, people can and will recover from substance use disorder. Thank you.
Thank you.
Thank you. Senator Blackburn.
Thank you, Mr. Chairman. And last year in Tennessee, we had over 3,800 overdose deaths. And these were primarily fentanyl. It was involved in 75% of those cases. Now, one of the things that I hear from our healthcare professionals and our law enforcement is they can't get their arms around this until the southern border is secured. And they talk about the uptick in using Narcan. They talk about the need to address these smugglers. I've got the Stop Fentanyl Border Crossings Act, which would add drug smuggling as a basis for Title 42 immigration enforcement. I know my colleagues have said there's a vote on the floor later this afternoon to address the border. It's an immigration bill. It is not a border security bill. And what people want to see is for all of this trafficking to stop and to stop pushing these drugs into our communities. And I appreciate you all being here. And as you've heard, we've done a lot of bipartisan work on medically assisted treatment. Senator Hassan and I have worked on some provisions. Senator Thune and I are working on allowing states to waive the IMD exclusion for substance use disorder treatment. And I fully feel like that any treatment that we have has to include prevention as well as the treatment, and then also enforcement, and making certain that people have access to that continuum of care. Recovery is not, as you have said in your testimony, this is a long road. And not everyone is willing to talk about that. But we have the Telehealth Response for E-Prescribing Addiction Therapy Services Act, the TREATS Act. And Senator Whitehouse and I and others on this committee have worked on this because it would address some of those barriers that a lot of individuals face as they are trying to get the care they need. And it would give that critical support. Dr. Herron, you just talked about this, in underserved and rural areas, and getting that help to people. It would leverage telehealth services. So I want to come to you, Dr. Herron. When we talk about the TREATS Act and how it would enhance that accessibility and efficacy of these services and e-prescribing, talk a little bit about how it would fill in those gaps in service and why we need to do this.
Thank you for your question, Senator. Telehealth has been one of the greatest innovations to ever come to behavioral health, and it's one of the good things that came out of the terrible tragedy of the COVID pandemic. We have seen incredible improvements in access, in engagement, in quality of care through telehealth. As I mentioned earlier, geographic restrictions.
What about compliance?
People are much more likely to engage and remain in treatment when they have multiple options to access care.
Okay.
So hybrid treatment options are really wonderful, where you do have the ability to still see a treatment provider in person and are able to do certain things that benefit from those face-to-face interactions, and the combination of doing that with the ability to access remote care. People no longer have to arrange for child care, take off time off of work, figure out transportation, how to get there. What could be a 30-minute, really the whole time face-to-face with a therapist was a 2-hour, 3-hour event to be able to leave, travel, wait in the waiting room, do all of those things. So people are able to still get the same quality of care in a much more efficient way. One of the things that's essential about the TREATS legislation is the addition of the provision about audio-only telehealth.
Yeah.
I do want to stress, and it's hard for us all sitting here on our smartphones to remember, many, many Americans do not have access to high-speed internet, to devices with cameras, to phones with data plans that they can use to access video. And so the addition of audio-only services as part of the treatment landscape is really essential to maintaining access for people.
Thank you. I'm almost out of time. Dr. Perrone, I will send a question to you. I want to talk about prescription opioids and those that are dealing with pain. And as we look at the overuse in the prescription area, how that affects the use of heroin and fentanyl. But I'll do that in writing. Thank you, Mr. Chairman.
Time of the gentlelady's expired. I'm also interested, Senator Blackburn, in that question about the prescription, so we'll work with you on it. Senator Casey.
Thank you, Mr. Chairman. Thanks for the hearing that you and the ranking member are providing an opportunity to have us be a part of. I want to thank the panel for your testimony and your willingness to serve in the trenches on these issues. Really important and difficult work that you do. Thursday's often a very busy hearing morning, so that's why a number of us are in and out. But I want to direct maybe just two questions to Dr. Perrone, because I know we're at the end of the hearing. Doctor, the first one is about barriers to treatment. In your testimony, you mentioned that only 11% of people with opioid use disorder receive medication. That's due to several factors, including cost. I introduced a bill called the More Savings legislation, which would eliminate costs for opioid treatment and recovery support services for people with private insurance plans, as well as people enrolled in a new Medicare pilot program. So those two groups of individuals. The bill will also increase federal funding for Medicaid treatment programs. Doctor, can you expand on some of the barriers to treatment and explain how decreasing barriers and costs could result in more patients getting access to needed care?
Thank you, Senator Casey. So we, just for example, I mentioned a patient that I saw a couple of days ago in the emergency department. We started her on buprenorphine. That patient, when they go to a pharmacy to fill that prescription, she was a little bit far from our area. She was previously from the Lehigh Valley, So at the pharmacy, they may say, "You're not on my list. You've never filled a prescription here. You're out of this area. We're not going to fill it." So the pharmacy barriers we really haven't touched on today, but there's tremendous stigma and other issues. And then pharmacists are also driven by their fear of regulatory compromise. So, it's a double-edged sword on their end, but they are very reluctant to be as collaborative as they could be because they're really worried about, what happened in the opioid crisis with overprescribing of opioids. So we need to mitigate that barrier. I think, incentivizing treatment is a great investment. Some insurance companies have come to me and said that we're going to pay additional reimbursement because if you start a patient on medications for opioid use disorder, that decreases our costs as an insurance company. So the ROI on medications is tremendous, not to mention the life-saving and other productive components of the success of medications.
Thank you, Doctor, for that. The rates of substance use disorder among older adults over the age of 65 has increased in recent years, with nearly 4 million older adults reporting a substance use disorder just in 2022. The number of older adults needing SUD treatment has tripled from from 2000 to 2020. Unfortunately, older adults are often overlooked when developing screening, prevention, and treatment strategies. Compounding these challenges are the limitations of Medicare coverage for substance use treatment and the dearth of data available to promote understanding of how best to care for older adults with substance use disorders. What are some of the gains, or I'm sorry, what are some of the gaps is the better word, the gaps in Medicare coverage that would make it difficult for older adults to access care for substance use disorders?
That's a great question. Thank you. You know, most of my patients are covered by Medicaid, so most of what I can speak about is access to filling prescriptions via Medicaid, where it's generally covered in Pennsylvania, whereas Medicare might not be covered and the patients may not have additional plans. So including medications in the, some component of a Medicare plan would be really important. And a lot of older adults have resulted in opioid use disorder primarily because they've been exposed to medications in their journey of, having more medical consequences and being treated with these medications. And then, the medications are no longer prescribed. And then they, literally we see patients quite commonly in that age group who, just go and buy something on the street because it's widely available to treat their pain.
Doctor, thanks very much. Thanks, Mr. Chairman.
Thank you, Senator Casey. Look forward to seeing your important legislation and having more discussions about it. Senator Daines will be our last witness.
All right. Chairman, thank you. Ranking Member Crapo as well. Just before I get into my line of questioning, my comments, I guess Senator Blackburn brought up the point that about what's going on with this vote this afternoon regarding the border. I think it's safe to say I've personally been to the southern border more times than any member of this committee on the other side of the dais from the Democrats. I've spent a lot of time on the southern border, sometimes going the night shift from 10 p.m. to 6 a.m., watching what's happening. This vote this afternoon is a political stunt. If we're serious about solving the crisis on the southern border, the Democrats should go down to the commander-in-chief, the Oval Office, and ask President Biden to reverse the reversal of the policies that he put in place of executive action after President Trump left office. It really isn't that complicated. And so this has now become a political crisis for the Democrats. The border crisis is a crisis, but now that it's a political crisis, Leader Schumer's decided he's going to put this bill on the floor so they can cut some commercials here to try to save some of the senators who've got tough races back home because the American people see the disaster and the tragedy of this invasion that's going on the southern border, and linked to that, because the Border Patrol agents do not have enough resources. It's a zero-sum situation as they're apprehending nearly 9 million illegals have come across the border since President Trump left office, and that allows the Chinese to ship the fentanyl precursors to the cartels. They manufacture them and then ship them in the United States. In fact, by the time it leaves the Rio Grande until it gets to Montana is about 48 hours now with the efficiencies of the Mexican cartels. And what is going to happen this afternoon, frankly, will be seen by the American people as a political stunt in trying to save an election. Last month, I co-hosted a discussion with Senator Cardin in the Finance Healthcare Subcommittee on the opioid epidemic in our country. I'm glad the full committee decided to spotlight this issue as well. Driven by the man-made crisis at our southern border, fentanyl manufactured by Mexican cartels using the precursor chemicals from China have flooded across the border, and they've been in every community in Montana and sadly across the nation. We're a northern border state, but we also have now a southern border crisis. In fact, in Montana alone, the state crime lab has preliminarily reported 80 overdose deaths involving fentanyl in 2023, an increase of 1,900% from 2017 when there were just 4. Although we have therapies and FDA-approved medicines for treating substance use disorder, accessing this care has long been outside the traditional healthcare continuum, resulting in a fragmented system and a challenge for patients to navigate. In the subcommittee's work last month, it was apparent to me that the care provided for substance use disorder across the country is often a reflection of each individual community, its specific needs, and the community partners available to help create local continuums of care. Dr. Herron, could you share with the committee this hyper-local aspect of providing substance use care and the importance of community partnerships as well as coordination to treat patients?
Thank you for the question. Yes, I think I have an interesting perspective in that I work in a federally qualified health center in New York that includes urban sites, rural sites, and suburban sites. And the needs of each community are both different and the same. I think the access to evidence-based, high-quality, low-barrier treatment is shared among all people with addiction. But building those community partnerships in order to build trust, to build connections with additional resources, with schools, with recovery-oriented communities, organizations that can help to do a lot of the preventive services you've heard about today are really essential. And so understanding the needs of those different communities, whether they be the variable access to technology, to transportation barriers, differences in income levels and insurance demographics in each of those communities really do require a nuanced approach to the services you're providing in that local environment.
Dr. Herron, thank you. I have one more question, final question for Mr. Vezina. When Senator Stabenow and I led the Finance Committee's efforts on the Mental Health Workforce Working Group, one of the proposals I worked on was increasing Medicare participation for peer support for individuals with mental health or substance use conditions. Mr. Vezina, your organization provides a number of resources to individuals struggling with substance use and addiction, including peer support as well as mentorship. Could you speak briefly about the role of peer support in the substance use disorder care continuum, especially for our youth and our young adults?
Yeah, thank you so much for the question. You know, for hundreds of years, people in recovery have helped other people recover, and it's been largely voluntary. The first drug and alcohol counselors were a lot of people in recovery. A lot of you know, the evolution of how we treat addiction has been pushed by people in recovery. And so this peer support occupation gives people in recovery a specific occupation to go out and motivate people to change. That's what peers can do. They can help motivate people. You know, people who have addiction are oftentimes ambivalent. They want to quit and they want to use at the same time. And that's a natural human kind of, you know, condition. I want to stop eating candy and I want to eat a bunch of candy at the same time. I think everyone can share that duality. And so peers really can help people motivate to change. And so at 4D, we have about 100 staff and we have 5 recovery centers. And that's all we do is go out and motivate youth and young adults to get into recovery and to sustain their recovery. And so you can put peers in pretty much any setting and help people motivate, to get motivated to participate in the recovery process.
Time of the gentleman's expired. I want to thank all our witnesses. We have spent 2.5 hours here today trying to learn about the enormous healthcare challenges. And I underline healthcare challenges because we are the committee with jurisdiction over healthcare, over Medicare and Medicaid and these essential healthcare programs. And what I like the most about what we've done for 2.5 hours is overwhelmingly most of our time has been devoted to looking at issues like best practices, state-of-the-art treatment, prior authorization, which I think is a huge ripoff led by insurance companies. And all 4 of you have made a big, big difference in terms of getting the focus on these healthcare issues, which frankly haven't gotten the attention that's warranted. And without Mr. Vezina coming up at that day at Fred Meyer in Oregon and saying, we got to dig into these healthcare issues, you know, the headlines would be about something else. So I really appreciate what you've done today and gotten the focus back on the fact that so many people are addicted. We heard Senator Bennett talk about when he hears about a death, he looks at it completely differently. My wife and I are older parents, and I'm going to close with this. We have twins that are 16. Whenever they go out, I say, come back here. William and Ava, come back here for a minute. And they go, oh, God, Dad's going to give us the fentanyl lecture again. And I say, yeah, I'm going to give it to you because this is something you can't play Russian roulette with. You can't just say, oh, I'm going to take a sample. You say you can't have stuff at parties. You can't do any of these kinds of things that you all and specialists are warning us about. So you've helped us with getting the state of the art with respect to health care, what this committee does. This committee, to its credit, by the way, has focused in a bipartisan way on these health care issues. A lot of people didn't think it could be done in terms of the gun safety bill. They didn't think we would be able to get these important provisions that relate to the school issue. And Mr. Vesna, you were very, very thoughtful in terms of assessing how it might have been different for you if we were moving in healthier directions when you were a kid. So Godspeed. May see you on the plane in a few hours, Mr. Vesna, if we try to make the trek back. But thank you for a particularly good hearing that zeroes in on the issues before the committee. With that, we're adjourned.